on this computer.
All the endpoints have been tracked.
Okay, wonderful. Thank you all for coming. The lecture tonight is Complex Diagnosis, How to Manage in 20 Minutes. Can somebody mute themselves who's making a noise? Thank you. So our learning objectives tonight: how to make a correct and fast diagnosis, what to do when you can't be certain of the diagnosis, and the role of pharmacology in that. So, active self-treatment of a facial wound with a biologically active plant by a male Sumatran orangutan. It came out in all the papers recently, but this is the article from Nature about this. So I don't know how many people saw this, but this is the first time someone's seen a non-human actually treating themselves medically.
Thank you.
We have this orangutan. He has a very clear wound on his face. The orangutan has gone and found a plant and mushed it up, put it on his face, and over time the plant has helped, or maybe time has helped him to heal his face. They have seen this sort of thing in other animals before, but not quite the same. Jane Goodall, the chimpanzee guru, first spotted self-medication in the form of eating whole leaves by chimpanzees in the 60s, and similar behaviour has been seen in bonobos, gorillas, and gibbons. But this is something new from an orangutan. Okay. So the lecture, How to Make a Diagnosis in 20 Minutes, is a title that I had for a lecture given in 2016. However, we no longer have 20 minutes for an appointment. We now have 30 minutes for an appointment. So that's great, but I thought I'd stick with the original title. But we do now have that extra time to see patients. Maybe 20 minutes, you made the diagnosis, but you do actually have to treat them as well. So why have we got 30 minutes instead of 20 minutes? I think this is an important point to state to people. It's nothing to do with fallow time. That may have been why it came about, but it's no longer relevant. Nobody is keeping fallow time between appointments. It's nothing to do with coffee time. It's nothing to do with the NHS just wanting to be nice to us or to our nurses. I'm not saying they're bad people, but they're not doing this to be nice. It's because the commissioners understand that quality care takes time and are willing to put themselves on the line to do that, put their necks on the line when the newspapers are full of access problems to do that. And they could say to us, why don't you see 6 patients now, 10 patients now, get rid of the access problems, don't worry about treating them well, just fob them off. The guidance nationally says that we're supposed to have 20 minutes for an emergency patient. It used to be 15, but it's been up to 20, yet we're giving 30 minutes per patient. And the reason is because they trust us to try and give the best care possible. We need to use it wisely. We need to be treating our patients well, not fobbing them off, because if we do that, we're going to be down to 15 minutes again. So we were lectured previously in 2014 by Dr. Sharon Stern, a specialist endodontist who myself and Adrian both refer to and both rate very highly. A sound diagnosis can only be reached when information is systematically collected from the patient. So we have our template notes on Dentally, use them. There's a history. You take the history. I'm not going to repeat everything. We've gone through this in previous lectures, and everyone knows how to do this to a greater or lesser extent. The examination, looking for all the things we need to look for. Percussion of a tooth. Every tooth that is relevant to an endodontic diagnosis needs to be percussed. It doesn't mean you've got to whack them hard, but you've got to percuss a tooth. You've got to palpate the sulcus, because that's going to tell you of where exactly which tooth is paining. You've got to take pockets for the teeth that are relevant. You've got to do sensitivity testing, be that with endofrost or be that with an electric pulp test. Yes, in theory, you could use a heat test, but nobody seems to do that. Ethyl chloride is endofrost is colder.
Smokes.
Then you've got to take an X-ray. As I say, if somebody can put their camera on, it would be helpful, because it is useful to be able to see a few faces. I've got a couple there, thank you. Radiographs. Most teeth need a radiograph. So I was doing what I do in everyone else's talks and going for a walk in beautiful sunshine. Wonderful. Right, you come up with a possible diagnosis. There are, broadly speaking, 2 diagnoses that you can make. This is an article from Tara Renton, King's College, regarding dental or dentogenic pain. And dental pain is a common pain. She deals with the stuff that we don't deal with, those nerve damages and the more severe pains. But you've got odontogenic pain, which is pain referring to something that's coming from the teeth or their supporting structures, the mucosa, the gingiva, the maxilla, the mandible, or the periodontal membrane. Just water tonight, everybody. Or there's non-odontogenic pain. And these are mainly conditions that we need to recognize rather than treat. We're not there to treat atypical facial pain or even to diagnose it, but to recognize that this is not toothache. And then you've got a couple of others that are a bit in between, TMJD or whatever it's being called this week, or acute sinusitis. These are both conditions that we see regularly in the emergency dental clinic. And yeah, we sort of should have some sort of knowledge of how to treat them at the time of the problem. Non-odontogenic pain. So the paradigm matters, and persistent pain is different from acute pain, and we dentists can help with that. This article is from the BDJ very, very recently. I think it's even this week's edition. Dental professionals often expect and are used to treating pain that has a clear, organic, and likely pathological cause. Patients visit the dentist are going to share this expectation. And when it's a chronic pain, it needs to be thought of in a different way. So persistent or chronic orofacial pain is pain that is different. It's defined as pain that persists for more than 3 months. That doesn't mean if someone's got non-odontogenic pain, they've only had it for 2.5 months, you can't tell them it. If one or more parties in the conversation, that's the dentist or the patient, think that the default cause of pain is tissue damage, this dissonance is not going to bode well for successful pain management. And you've got to communicate that both acute pains and persistent pains are valid forms of pains, and that needs to be addressed. I always talk of the phantom limb pain. My late father lost a leg and he had pain in his foot. It wasn't because he was bonkers, to put it, use a very technical term, but that nerve, broadly speaking, goes from the foot up to the brain. The place where you have pain is felt in the brain, but it's also coming from the foot. And if you stub your toe, you get pain. It's felt, goes up the nerve, and you feel it in the brain. If you haven't got the toe there, clearly you haven't stubbed your toe, but you've still got a very genuine pain. And that has to be dealt with in a different way. Clearly, you can't put medication on it or anything like that. In our case, most pain that we see is a hole in the tooth or a broken tooth or a problem with a gum. We can physically see something there, but not always. So we've got a number of cases. A lot of this evening is on cases. JN, a male patient, late 60s, fit and well. I saw this patient in February. He hadn't seen a dentist for about a year, so reasonably regular attender. Complaining of intermittent pain upper right 4, not affecting his sleep, not affected by hot, cold or biting. It was becoming more frequent and intense, and he had it for about a month. He's got an upper and lower chrome denture, which are about 5 years old, and they're a good fit, and he's happy with them. Nodes and soft tissue, NAD. TMJ click, no pain, it doesn't lock, but on 2 occasions in the past, he has difficulty biting. He saw a specialist at Watford General Hospital, it's a local hospital with a Max Axe department, and then he saw a specialist about his hearing and dizziness, who thought he'd broken his jaw in the past. And I'm not quite sure where that comes in, but there was a thought of that. No caries, generalized attrition, guy in his late 60s, so that's not abnormal. Missing teeth, obviously. Oral hygiene, reasonable. Nothing tender to percussion. Sulcus normal. Endofrost, upper right 5 positive. I'll show you in a moment the x-rays. So there's our x-ray. The upper right 4 is rotated and it's got this root canal and crown. The 3's got a crown on a root canal and crown as well. Obviously, the 4 and 3, one doesn't take an endofrost test if you know that they're non-vital, unless you're trying to just check what somebody's feeling might be. There's something going on in the 6 space over here. 5 looks okay. There's no deep pocketing either. The bridge, which is going from upper right 3 to upper right 1, is bubble test negative. If anyone noticed where you press on the abutments, if any saliva starts bubbling out, it means the thing's debonded. Diagnosis uncertain, but could be gingival pain between the upper right 3 and 4. I mean, I was sort of clutching at straws, but couldn't really see a clear odontogenic cause. So I said, clean your teeth a bit better. Those crowns clearly are not a perfect fit. They've probably not been a perfect fit since they were made, however many years ago they were made. What have I recommended? A bit of chlorhexidine gel, maybe, see if that helps. So just going back to the x-ray. I don't know if anyone else is seeing anything else that I'm not, but it's always easier to see something else when you know there's a problem.
Scott,
Okay.
can you go back there? Which were the teeth? We've got the tooth which looks
That's
like a
So we've
molar in the
got,
middle. Is that two teeth
yeah,
across?
no, right. So you've got on the left hand side of the image, you've got the upper 7 or 8. You've got possibly a retained bit of root fragment 6.
Yeah,
You've got the 5 here. This is
Yeah.
the 4, the one he's pointed to, and this is the
Right.
3.
right, okay.
And the 4's at an unusual angle, see it like that. And yeah, you could argue the root canal's short, but there's not much canal there, and there's clearly no sign of periapical pathology. Okay, so I saw him again 2 months later. The pain comes and goes. He's still pointing to the upper right 4. Taken another X-ray. I've taken a full set of X-rays of his mouth. I could have shown you anything, but just showing you a bit further back. There's nothing obvious there. The pain can affect sleep. It can come for no reason. It's not affected by hot, cold, and biting, and painkillers help. All the tests as before. So endofrost, you've got the pocket, no deep pocketing, you've got no tenderness to palpation, no tenderness to percussion. And he's okay biting on the cotton wool roll. Bite on a cotton wool roll, open your mouth, see if it hurts. But when you're biting, see if it hurts when you're not biting. Somebody's put a CBCT could help. Yep, definitely. Don't know who you are, but you're definitely right. He's had multiple bouts of bilateral sinusitis in the past. Okay, that becomes interesting. Zygomatic tap, go like this. That's normal. Oh, thank you, Vian. And what else? I don't know what the diagnosis here, but I'm pretty convinced it's not dental. So I have recommended he be referred to a pain specialist, and I said, well, you could have a CBCT scan, get a 3D X-ray as well, put it to the patient. Vian, you're quite right. Or I could refer you to an endodontist, and I didn't really think that would help because if I spoke to Sharon, she'd say, well, you've done all the tests. It's not necessarily something she's going to deal with differently. Sinusitis, definitely possible, definitely within that. Anyway, having offered him these 3 choices, he agreed to be referred to a pain specialist, came back to me 5 minutes later and said, actually, can I have a CT scan, please? Because I think the pain specialist will start recommending medication, and I'd like to have checked everything else first. Okay. On reflection, I probably should have said go to the pain specialist, because now I've got to refer him to for the CT scan. I've got to get it back. I've got to report on it, and then refer him to a specialist. However, if it does show that in 3D there's a massive apical pathology or there's a fractured root somewhere, then he's right, and this is the correct way to go. And then we will treat it as an odontogenic problem. I suspect it will show some sort of sinus problem, and the CBCT report will say you need to see a sinus person as well as a pains person. Okay. Any questions on that case? I think that's as far as we go with it. So next one's a 94-year-old female. Medical history, yeah, fairly normal. Hypertension, diabetes, a few medications. Stabbing pain, lower left quadrant, last 2 weeks. A&E, she's already been to A&E, it was that bad, and they said go find a dentist. Not affecting sleep, pain comes and go. It's worse when she yawns. She can get spontaneous pain. Not affected by eating, hot, cold, or painkillers are not helping. And it's not obvious why it started. She doesn't have a lower denture. She is missing all her lower teeth. I think she had an upper denture. It's tender in the sulcus when you probe there, when you palpate. On the ridge near the lower left 3-4 region, there's no swelling, redness, or any other signs of infection. There's no deep pocketing. Here's your X-ray. there is a retained root there. Patient totally compos mentis. Remember that she had an extraction many years ago where they left a bit of root in. I think some of us do that from time to time, sometimes a bigger bit of root than that. And I thought about taking the root out. I didn't think it was going to be an overly difficult extraction, even with her medication, but spoke to a colleague who was available at the time, and then just decided, you know what, can you do a diary of your pain? And can we then refer you to a pain specialist, which we did. Pain specialist, the old medicine said, trigeminal neuralgia plus a bit of dehydration, and sent her for various blood tests. I don't have what the final results were, but that's where it was going. And certainly I haven't been asked to take that tooth out. As an aside, those who are watching with more than one person on the camera, can you let Lisa know so she gets you both down on the register? Thank you. Okay, so it would be tempting and easy to have taken that tooth out. I wouldn't have caused her any great harm, but I'd have given her further pain, further expense for no great benefit, I don't think. The next one's an 84-year-old lady. Medical history, general anxiety, arthritis, standard medication, nothing too exciting. Pain affecting sleep, top left yesterday. And she's had this problem for more than a year. More than a year, this doesn't sound acute, does it? She's had an extraction of the upper left four and multiple courses of antibiotics. Yeah, okay, you can see where I'm coming on this, anyone who knows me. Nodes, pockets, and the sulcus are all normal, so palpation's normal. The upper left 5 is mildly tender to percussion. Endofrost negative. And here's our tooth. So we've got canine, we've got the lateral, we've got 5, endofrost negative, mild TTP, no deep pockets, no nodes, sulcus normal. Okay. Diagnosis, a pulpal diagnosis, is it non-vital, apical diagnosis, well, it's mild TTP? Have we got some sort of symptomatic apical periodontitis going on? But sulcus is normal. There's no caries in that tooth. I presume there's no sign of a fracture in it either. Let's consider it a little bit more. That's the x-ray of the 2 and 3. Not much going on. Maybe there's some caries in the 2, or maybe it's an old filling. I can't remember. I don't think it's relevant. Upper left 2 and 3 are also endofrost negative. Okay, so she's an old person who doesn't feel endofrost. The canals have sclerosed away a bit. Oh, we've got pulp tester out. 1, 2, 3, 5 positive. So there's a crown on the 1, 2, 3, 5, all positive. Right, that's telling me something. If I got 3 teeth positive, 1 tooth negative, I'm looking at non-vital, but I've got positive everywhere. No recent respiratory infection. The zygomatic tap is negative. She's okay biting on the cottonwood roll. My diagnosis here is non-odontogenic. She's had this pain for over a year. She's had the upper 4 extracted. I think it's fair to say that this patient has probably suffered severe damage to her teeth. Somebody has extracted that upper left 4, probably without good cause. Now, obviously, I'm not saying that as definitive judgment against somebody. I don't know the situation. I don't know whether the 4 had a provisional hole in it, a deep filling, an old root filling that was no good. But whatever it is, it's been extracted and the pain's still there. And she's had all those antibiotics prescribed. So what's this done to her gut microbiome? Who knows? But it hasn't done anything positive to it. We can be pretty confident of that.
Scott, just one comment. In terms of the electric pulp test and endofrost, I know you tend to rely on them a bit more. I'm much more cautious with false positives and false negatives, but I get you quite like that.
Well, this is it. You've got this case. You've got a potential false negative, and you've gone back in and you've done it again and you had a look. You do get false positives. You do get false negatives. That's the science. The science says that. The guidance says you've got to get sensitivity testing for every tooth. And it's not to say that you would take one thing on its own. If you looked at the beginning of this, we've got a bit TTP, we've got a bit of non-vitality if we only tested one tooth. But when we've taken it in the round, I am very confident this is non-odontogenic. I only saw this patient a few weeks ago. I can't, it's not one where I've seen them a year ago and I've got follow-up and everything else.
And
What's
lastly, the
next?
zymatic tap. What do you hope to get by that? Is that very? Does that give a clear guidance of the sinus? I always find that particularly difficult to diagnose.
Again, it gives some guidance to the sinus. We're going to show another case with that later, which is absolutely wonderful for it. Um, it doesn't prove anything on its own, but it's a useful test to do, and I'll come to that definitely. Dental protection, say 80% of patients who have harm don't complain. 80% of complainants never had harm. This lady has had harm in 2 counts and hasn't complained as far as I know about anyone. The next case is a 37-year-old female. And had I have extirpated that tooth, I'd have got nowhere. I'd have found it vital. It wouldn't have dealt with her pain. 37-year-old female. I've never seen this patient. This is a patient who I picked out from the cases that have been seen by one or two of us dentists within the system. She's complaining of pain in the upper right quadrant. She had crown done upper right 5 2 years ago. And this is what the notes say. No issues seen in the mouth. Okay. Percussion palpation of sulcus, pocket depths, endophos cold test not done. Well, they didn't write that, but they didn't note anything. They just left it blank. So as a reasonable prosecutor, one would say it wasn't done. If we want to be generous, let's say it was done but not noted. And here's your x-ray. We've got a not unreasonable root canal filling on the 5. We've got a crown that's not brilliant but not terrible. Elsewhere, can you see something at the apex of the 4? Maybe, but probably not. No obvious caries, maybe on the 6, but probably not. Bone level's good, no sign of calculus. Nothing obvious. The advice to the patient was analgesics to manage their pain. Nothing wrong with that. Certainly better than giving random antibiotics or randomly pulling out the tooth. This dentist was reasonably confident what they'd done. Okay, so we've got the same x-ray back up again. What should have been done differently, though? We should have done palpation of the sulcus. We should have done a pocket depths. We should have done endophos cold tests on the adjacent teeth to check they are vital. I suspect they are. I suspect someone's over-treated that 5 initially, but there we go. Biting cotton wool roll. Bite hard on the cotton wool roll. Does it hurt? No. Open. And does it hurt on opening? If it hurts on opening, we're dealing with a crack. Pretty much diagnostic. It's one of those things you've got to do it more than once sometimes to get to be fairly confident in your results, but it's definitely a quick and easy test to do. Zygomatic tap, as I say, have we got sinusitis? Then go back again. If nothing's showing, ask the pain history again. Get pain history from the patient again. Now, I'd say I don't know if possibly a third root not been filled. It's possible. Yeah, certainly these things are there. CT scan might be worth doing. I don't know enough about this case. I haven't seen it, but what I can say is that the dentist's notes are more likely what the dentist has actually done do not show enough to say that what the diagnosis is, and that's where they're lacking a little bit. Okay, next one, FB. Okay, this is a regular patient of mine, 49 years old, fit and well. I saw her in October, so 6 months ago. Routine examination, sensitive upper right 7 with some caries. No, everything normal, but a bit tender, probing upper right 7 mid-buccally. It was sensitive to air spray when my finger was not covering the side of the tooth, but if I covered it, it was okay. There was no real abrasion lesions. There wasn't anything I could really fill. I did a routine composite filling and I put a bit of fluoride varnish buccally, probably told her stick a bit of toothpaste on your teeth at night before you go to bed and try and desensitize it. Here's my hole. It's a pretty small cavity. There isn't anything to see, I don't think, inside that cavity. And there's my filling. I think it's pretty good. I mean, I'm sure I don't think there's anyone on the call who's into the staining and whatever else of upper 7s, but I think it's a good enough filling. I'm pretty happy with it. Told the patient to go away. I'll see you in 6 months. Unfortunately, she came back quite a few times. So a week later, painful when touched, including with room temperature water. Okay, So anything's touching it hurts. This pain is lingering for 20 minutes. It's not getting better, and no painkillers are helping since the day after treatment. Oh, sorry, it's not getting better, but she hasn't needed any painkillers, and it's not affecting her sleep. The filling's intact. The occlusion is checked and normal. There's an X-ray, and okay, the filling's not that far from the pulp hole. There's a root filling on the 6. There's crown on the 6. So I'll just go back. I mean, anyone want to pick a diagnosis yet? No, okay. I mean, I don't. So, but very tempting, it must be said. Oh, well, let's do a root filling on the 7. Let's extirpate. It must be too deep. Maybe I should have put biodentine there. I don't know, but it wasn't. I didn't think it was a particularly deep hole. Um, biodentine lecture in July. Somebody put up an answer. MB2 not filled. Yeah, you're good, Kanita, but possibly high pulp pool on the 7. Vian, yes, possibly. Certainly, I'm thinking down that road, but it's possible. I was thinking down the MB2 thing as well, because you are sort of right, Kanita, as well. You're both right. Okay, so CBCT was taken showing no significant issues. I mean, that's just a CBTC to show off what CBCT looks like, or a flagship. Possibly post-op sensitivity from acid etch. Possibly, yes. I don't get a lot of that, but it is possible. As we see the case goes on, I don't think so, but it's possible at that stage. All of these things, though, I'm not sure what I would do next, based on what I've given you so far. The root canal filling was done by a specialist 5 years ago. If you find a specialist who say they do everything perfectly, all their root fillings are perfect, refer to someone else because they're lying to you. Remove the filling, yeah, certainly possible. The problem with removing the filling is I'm then potentially I'm dealing with one possible cause, but I might be then drilling in a bit deeper again and creating a problem. But certainly I would have considered doing that, and it's a good thing to consider doing. It's always easier to think of taking out someone else's filling than your own. With your own, you've got more knowledge of what you did the first time. But you're quite right. So the specialist was Sharon Stone again. So somebody again who I say I've got a lot of respect for. And when it was done, the patient, but the 2 month review, and it wasn't like we've seen her every single day. She said she thinks the pain is now coming from the 6, not the 7. You know, it has changed, and the pain hasn't been constant. It's morphed. Can we use biodentine? Last time I was told none of the 3 nurses know how to use it. It'd be good to try it. Who is iPhone 3? If you want to say who you are, Peter. Yes, we can. The nurses need to show them how to use it. You've been on the course, Peter. It's there. Go ahead and use it for irreversible pulpitis cases when you're able to. You know, it's the nurse doesn't. You know, you can show the nurse what to do once you know how to do it as a dentist. Right. Coming back to this case, nose palpation of sulcus, pocket depth normal, very tender gums on probing the upper right 6, mid buccal, mid palatal. Okay. Are we dealing with a crack? The CTs didn't show anything, and a CT's been shared with my colleague. Endofrost now on the 7, it's a bit more positive than normal. It's not just normal, it's plus. But so is the upper right 5 plus. So if I just told you upper right 7, recent filling, pulp hold, plus, you say, right, take that filling out, put a temporary in, put some biodentine in, put some, extirpated, do we like? But it's giving me the exact same reaction on the 5 that we've all decided there's not much wrong with. And that's why it's important when especially when you're not sure, that you test adjacent teeth, test something else, see what normal is. Normal for that patient. And don't forget, this is diagnosed within 20 minutes. We're 3 months later, 4 months later, not sure, multiple tests. You can't always diagnose in 20 minutes. The endodontist and myself have decided that there's no point going to the specialist endodontist. She's not going to see anything I haven't. We've been speaking throughout this case, from each appointment, CT scan. There's a lot of dialogue going on here. And unfortunately, most people don't have that ability to speak to a specialist. If you're doing the emergency session, Anything before midnight, you can phone me, you can phone Adrian, you can phone Huma, Sarah, whoever's on the rota, call us if you've got a question. If you're working, there's 2, 3 other dentists there. Speak to them as well, because between you, you get things worked out. At 5 months, upper right quadrant is mostly okay. She gets the odd pulse and twinge with hard foods and sometimes with liquids. Upper right 6, mid-palatal pocket 4 mm, tender pocket on BOP. There's no crack at high magnification with a microscope. There's no crack on that CT scan. Upper right 5, 6, 7, not TTP. Sulcus normal. Now we've got a normal reaction to endophthalmos. And maybe it was just little sensitivity due to the etch, due to the closeness to the pulp horn. I'm still uncertain of it. I'm wondering, have we got a low-grade pulpitis in the 7? Have we got a fracture in the 6? Have we got sinusitis? Have we got some other non-odontological problem? I don't know. I can guess on any of them. But my management and the patient is happy is to monitor. She can call me whenever she wants. She can call the specialist whenever she wants. I think the specialist notes when she did that tooth was that she couldn't quite get to the end of MB2. There was some sort of difficulty in doing that. As I say, if a specialist can you, they can always achieve everything perfectly. They're telling you fibs. The next case is a 22-year-old fit and well male. Seen by a colleague of mine last week in Croydon. We were there together working. I did an emergency session, so I'm going to say I actually saw some real patients on a real emergency clinic. I do see emergencies within the NHS, within the same system that we do fairly regularly. So it's not, do as I say, not as I do. Seen by a colleague of mine, complaining of continuous pain upper right quadrant, affecting sleep. Not affected by temperature, and paracetamol helps. Mild TTP on all of them. Sulcus pockets, endophthalmos normal. There's your X-ray. What can you see? Anyone want to say that what they can see there? Healthy. Maybe caries on the 6, but it's overlapping, difficult to be certain. Not a lot, yeah. Diagnosis, anyone certain? Okay, we'll assume everyone's equally uncertain. Took a bite wing as well to see if that showed anything. You've got a lower 8 that's impacted. The 6 is still overlapping the 7. So anyone who claims they can get 100% or 95% of X-rays with no overlap is, how you get a flat thing to take a non-overlapping image of something that's curved. I'm not sure. If anyone knows the answer, do tell me. No caries, no obvious fractures. I've put the loops on this one, magnified loops, and tender right TMJ, tender right lateral pterygoid. So this is where you're palpating the sulcus. You go a bit further back than all the teeth, and it starts to hurt. Generalized severe attrition for the age. He's 22, so we're not talking about a 70-year-old this time. Provisional diagnosis, bruxism induced pain, maybe. But the dentist who saw this wasn't 100% confident. She could see there's something going on here. I'm not certain what the diagnosis. Speak to your colleagues. Who else is in the room? Come and have a look. It didn't quite fit. It didn't quite seem the right diagnosis. We did think that if this was an NHS GDS case and it was late March and you had to finish your UDAs, you might prescribe a splint. Bruxism-induced pain might help, but probably won't. We had another look. We checked all the results. So she brought me in. I checked all the same tests. I got exactly the same results she did. I didn't see anything she hadn't seen. I didn't get different results that she got. Biting and relieving from the cotton wool roll, nothing. So we're not looking at a fracture, I don't think. I rechecked the history. Take the pain history again. Have you had a recent cold, COVID, flu? Sometimes people say, no, and I've tested for COVID 4 times in the last 2 weeks. Oh, hang on a second. Why'd you do that? What was wrong with you? What made you do that? Because people aren't testing for COVID unless they think they've got something. Yeah, occasionally it's, I saw my elderly mother for the first time in months and thought I should, but okay.
Oh, hi.
Don't check.
Oh, okay.
Pardon?
Yeah.
Is that something you're sharing or you've just unmuted? Okay. So recent upper respiratory tract infection, zygomatic tap positive on the right side only. Okay, this is looking pretty good for sinusitis. You can get them to lean forward. Does it hurt when you lean forward in your sinuses? If the answer is yes, you've got another definite sinusitis. Does it hurt when you jump up and down, when you're running, when you're playing football, when you head the ball, whatever it might be relevant. This was acute sinusitis. I'm pretty darn confident of that. And that's where the zygomatic tap comes in. Other times you do it and you're not really sure. The nice guidance on treatment of acute sinusitis. So I looked this up for the lecture and I've learned something new. I didn't know this properly. No antibiotics. You'll be pleased to know that I was aware of that one before. Antibiotics are not indicated for acute sinusitis. Acute sinusitis is usually viral. If it's bacterial, it's still not indicated to give antibiotics. Analgesics, a paracetamol or ibuprofen. Nasal saline or nasal decongestants can be considered for congestion, although the evidence is lacking to support their use for this indication. But no harm in telling them to do it. There is no evidence for oral decongestants, for taking a tablet, for antihistamines, for mucolytics, for steam inhalation, or for warm face packs. Now, I've always told people to go for the steam inhalation, stick your head over a bucket of steam. I know, at least it feels like you're doing something, but there's no evidence for it. When I next get something similar, will I do it? Well, I might do, because at least you're not going to cause any harm unless you burn yourself. But it's not, the recommendation is analgesics, maybe nasal saline, maybe nasal decongestants. Go to the pharmacist and buy something you like, see if it helps, but it's likely to go away of its own accord. I always tell patients, if I've diagnosed sinusitis for them, this is the best diagnosis I'm going to give people, because no dental treatment is indicated. I don't need to drill your teeth. I don't need to give you any fillings. I don't need to take any teeth out. You're going to like that. No antibiotics are needed. I don't need to muck up your system. I don't need to give you medication that's not going to help you. Any questions at this stage? I'm going to share Pam's phone. Okay. Right. I'm happy to take questions later if people want to, which people do. I'm also happy if you've got a question you're a bit embarrassed, message Lisa and she'll do it. Can you elaborate on the zygomatic tap? Yes. Mental health conditions? Yes. So mental health conditions definitely exist. And again, if you've got a mental health condition, we don't need to have a dental one of lacking teeth at the same time. The zygomatic tap, lean slightly forward. You can be lying backwards as well. Take one finger each side and tap the zygoma. Does that hurt? If it hurts a little bit on both sides, that's probably just because, it does hurt a little bit to tap people on both sides. Just as if you hit them hard enough with the back end of the mirror, it hurts. But if it only hurts on one side, you've got a very definite diagnosis. And if it really hurts a lot, you've probably got sinusitis as well. If you then get them you sit them up, say, put your head between your legs. When you lean forward, you suddenly feel a lot of pain in your sinus region. They go, yeah, that does hurt. Again, we're looking at sinusitis. It's not always, but it's often there. Does that answer the question? Diabetic condition can cause neuropathy pain. Yes, it can. And lots of things can. I'm saying diabetic neuropathy is certainly something that could be relevant. I don't know if it was that guy. I mean, he wasn't known to be diabetic. He could have been diabetic. There's a million diabetics that don't know about it. I'll come to that sort of thing though in a moment. You could be right, but you could be wrong. And it's not our job to diagnose diabetes or diabetic neuropathy. It's clear if somebody says, yeah, I've got diabetes in the medical history and I've got neuropathy in my fingers, I've got neuropathy in my toes, I've got neuropathy everywhere. Yeah, you're starting to think down that line for teeth as well. I'm going to share my screen again. Okay. What do you do when you're not certain of the diagnosis? In a lot of these cases, we're not certain. If in doubt, first priority, do no harm. For some reason, this is primum non nocere for our Latin scholars, and it's attributed to the Greek Hippocrates, the 5th century BCE. I don't know if we've got anyone on who is a Latin or Greek scholar. Why has this phrase been that is attributed to a Greek known in Latin in medicine? Am I weird to think that? I don't know. But do no harm. Start treatment with what you are sure of. So a guy comes in with all sorts of pain and occlusal caries in the upper 7. There's pain somewhere. I don't know what it is, but he's got a small occlusal cavity in the upper 7. Well, I'm sure of that. I can see that. Maybe I'm going to do a filling for him. Maybe there's occult caries. Maybe there's something. Maybe at least I can, if I do a decent filling on that upper 7, at the end of his half-hour appointment, I've done something useful for him. I've at least eliminated one possible cause of his problem, and I've not caused any harm in doing so. Redo your standard tests. So, you've done your palpation, your pocket depth, your percussion, your sensitivity test. There's loads of times when you start, you test again and you find that pocket that you missed the first time round. Suddenly you've noticed a 10mm pocket. I think that might be the cause of your problems. As you saw in that other case when I got out the pulp tester as opposed to the endo for a second time round, because I felt there was something odd. I've rechecked the history where we found the case with the upper respiratory tract infection. That was something that we hadn't picked up the first time. And the sinusitis. Don't be pressured to make the wrong decision. Don't be pressured by the patient. Don't be pressured by the nurse, the next patient waiting. Don't be pressured by yourself. Don't be pressured by me or anyone else. If you're not sure what's going on, don't do something you're not sure about. Consider fractures, TMJD, sinusitis, cardiac pain, non-odontological pain of all sorts. Cardiac pain, I've diagnosed once that I recall, and that was a telephone diagnosis. Somebody talking about pain on the left-hand side, lower teeth. It gets a bit worse when I climb the stairs. That is something to worry about. That is, I think you need to go to the hospital. I think you need to call 999. That sounds like heart. And, that was heart. I don't know if I ever met the patient afterwards, but I recall it, and it's years ago. And I got lucky, I guess, because, it could have been 101 other things as well. But, that's a red warning sign. Things like cardiac pain, things like sepsis. If you get a red warning sign, you flag it, 999, go to hospital. However, please don't diagnose outside of your area of expertise. We've all got an area of expertise. I'd like to think I know a little bit about emergency dentistry. But anecdotally, this isn't something I can say for certain. I don't have a paper on this. I find patients often latch onto a wrong diagnosis and a wrong management strategy far better than they ever latch onto a correct diagnosis or a correct management strategy. My dentist 25 years ago gave me antibiotics for it, and that worked wonderfully. I must have antibiotics for this. And my dentist told me this 20 years ago. The guy's wrong. You can see he's wrong. You can see that the diagnosis was nonsense. But that patient has latched onto it. I've got trigeminal neuralgia. No, you haven't. You've got an apical infection. But they've latched onto that wrong diagnosis. We're not qualified to make a diagnosis of trigeminal neuralgia, I don't think. Some of us may have worked in hospital departments or be, all medicine experts, and maybe they are. But I don't think all of us are. I certainly don't think I am. Okay. I can't see what that says. So how do I move this away? Right. So the role of pharmacology. Ibuprofen can be given up to 800 milligrams TDS in an average patient. I think if you read the rules, in some rules it will say 600, some 400, some packets are different. Ibuprofen is tricky because you can buy it in multiple different doses as well. But I'll go up to, for a standard normal sized person without any health conditions, I'll go up to 2.4 grams a day in divided doses. Paracetamol, 100 milligrams.
Scott. 800 is on
Pardon?
prescription. 800 is on prescription.
Yeah, but you can
packet will give half that.
Yeah, but the packet will say 400. But if you got, somebody can take 2 400s. Paracetamol, 1,000 milligrams QDS, so 2 tablets 4 times a day. The Oxford League Table of Analgesic Efficiency shows that those, which is basically multiple pain studies with, this drug against that drug, this drug against no drug, this drug against placebo, and it puts these two right up the top of it. We don't need to start giving people codeine, all these better painkillers. Well, they're not better for toothache. They just, in addition to giving you anything else, will give you constipation. So those are the painkillers to recommend. And not everyone should have maximum dose. Certainly, nobody should have an overdose. And if you suspect overdose, you've got to, tell them to get to A&E. You can call 111 or 999, depending on how big an overdose you think you've got. Those of us that are old enough to remember, they stopped selling paracetamol in packets of more than 16. The reason being that people would take paracetamol and kill themselves with it. And people at the time said, what a stupid thing. If you want to kill yourself, you go out and buy 1 pack of 16, then another pack of 16 from the next shop, and then from the third shop, you buy a third pack and you'll kill yourself. And it turned out, no, that doesn't work, because when people are in a bad mental health state, they don't think logically. They take 16 paracetamol, and somebody drags them off to A&E and they survive. Whereas in the past, if they'd taken 32 or 48, and there would have been a different situation. It's been a very good public health measure. Antibiotics should only be prescribed in the presence of spreading infection, lymphadenopathy, not a tiny swelling, proper swelling somewhere, fever, physical malaise. Okay, there's some people who, for one reason or another, at high risk of infection, you might get it a bit earlier than others. There's the guy who's about to go to, spend the next 4 weeks in the Antarctic or the jungle. And again, you might give him these just in case, take them with you just in case you need them. But fundamentally, most people should not be given them. There's a guy who's 6'4" and threatening. And again, you do that, you might prescribe. But for most people, you're not prescribing unless you're certain of a spreading infection. If you do have to prescribe, and we did have somebody recently prescribe in that's a situation where they felt threatened, you put it in the notes, patient demanded antibiotics, therefore prescribed. And you would send an email to your manager, to me, to Lisa, to Leanne, to Joe, to Adrian, preferably to a dentist, I think, saying, I prescribed to patient X because he was threatening. You don't want to put that in the notes because it doesn't look good, but it's date stamped when you email it to me. If it ever comes as a complaint, we don't get many emails along the lines of that. We do get the odd one, this patient was threatening, therefore I did X, Y, and Z. I would have taken the tooth out, but he seemed like threatening so-and-so, so I didn't. I gave him antibiotics to get him out the door. I understand that. It does happen from time to time. It shouldn't be happening 3 times a day. If you're taking the tooth out, do you still give prescription antibiotics presence of fever, swelling? Right. This is a question. So patient has an absolute swelling, they've got fever, they've got malaise, you take the tooth out. Do you still need to prescribe? It depends. There are times when you take the tooth out, you see a bucket load of pus come out with it. The swelling goes down immediately. And you say to the patient, how do you feel? And the patient says, I feel like I'm coming back to life. The patient is fit and well. I would not consider antibiotics remotely appropriate. That's one extreme. At the other extreme, you take the tooth out, the swelling is still there, just as when you incise a swelling and nothing but blood comes out and the swelling's still there. And the patient still feels just as ill as they did before, but then minus the tooth. Now, the tooth needed to come out. They've still got all those symptoms and they've still got a spreading infection. Yes, I absolutely would prescribe antibiotics to that person. And there's a range of people in between. Most people are somewhere on that continuum. And you start thinking, right, do they have any other medical conditions? Is that going to make me more likely to prescribe or less likely to prescribe? Let's say, for example, they're on warfarin. Well, I might be less likely to prescribe because when I prescribe antibiotics, I'm going to muck up their warfarin. How likely are they to get back to another dentist? If they're seen in London on one of our clinics, they will be called normally 3 days later. When I prescribe antibiotics to a patient, I will normally call them 3 days later. Why? Because I don't prescribe a lot of antibiotics. If you prescribe 10 antibiotics a week, you're not calling 10 people a week back because you've got a hell of a lot of work to do. But then you're prescribing probably too many antibiotics. Is that an answer? It's not a yes or no. It's a maybe, but probably not. Okay. Right. Next slide, please. Right. Talent is overrated. What really separates world-class performers from everybody else by Jeff Colvin. Normally, some of the books I've spoken about are by Nobel laureates. This guy is not a Nobel laureate, so I'm sorry to dumb it down, everyone, tonight. Has anybody read this book? If they have, then you may have my copy of it, and can I have it back? Because I couldn't find it when I was looking for it the other day to quote from it. Anyway, he talks of deliberate practice rather than innate talent. This is the concept. 10,000 hours of deliberate practice makes you good at anything. The more I practice, the better I get. Terry Venables, the old football manager, said practice doesn't make perfect, makes permanent. So if you practice rubbish, you get good at rubbish. My football coach, when I was about the age that Terry Venables was good, would make us practice doing bad headers, because he thought, well, sometimes it will help you then be able to recover from the bad header. You know, practicing a good header might have been a better thing to do, although we don't tend to practice headers that much in youth football these days. Anyway, 10,000 hours of deliberate practice will get you good at things. So that means you are practicing and trying to improve a little bit each time. You've got somebody teaching you, somebody mentoring you, somebody helping you. That's what we had at dental school. That's what we have within South West Southern Urgent Dental Care, within Heart Surgeon Dental Care. You've got people who can help. Ask us, and we're here to help. We all can aim to be a world-class emergency dentist. We can aim to be world-class at anything else. Now, in reality, whilst the sportsman needs to be world-class to win anything, a dentist needs to just be good. There's lots of dentists. I don't need the best dentist in the world, said the person who recommended this book to me. I need a good dentist who's vaguely local and that I trust. However, we all know a dentist who is below the level of Rakus the orangutan, the guy we met at the beginning who was doing a bit of, oral medicine or facial surgery, maybe. We don't need to name him or her, but somebody the other day did name one to me who was a local. Lisa, you will approve of who they named. Okay, follow-up care daily. So let's come back to that. That's pretty much the end of the important bit of the lecture. The next bit is internal housekeeping. I'm going to keep the video going because it's, those people that may watch it on YouTube later may want to watch this. But we've got slightly different forms for the follow-up care day list in London to what we have in Hertfordshire. And I know that Leanne's got a clever method of passing bits of paper across. Again, it's the same idea, but you do need to engage with this. And I realise lots of people are doing it wrong, which means I obviously haven't taught it well enough. The necessary care criteria have been sent to everybody by email. It needs to be read, because if you've not read it, you're going to struggle with the form filling. Lisa, Joe, Leanne, please send it back out to people. Certainly anyone who's got questions about necessary care or the follow-up care dailies, make sure they've read it at least. It does help. And we all know, I sent somebody an email about, will your lecture be on Zoom? I've signed up for it. And the response back, yes, it says so on the top line. We all make mistakes. We all don't read things. We all have too much information and don't read it. The date needs to be filled in. Your name needs to be filled in. So that's two simple ones, right? This is the form. We start off with the patient initials. Ideally, the receptionist fills in, but it doesn't really matter who does it. And then, does the patient have their own dentist? Which again is not always a yes/no question, but it's yes, no, maybe. But if they've got their own dentist, you put a tick there. That's it. You don't need to do anything else with this form for that patient. They've got their own dentist. You deal with the problem today. Someone else is going to deal with their problem another day. At the end of the appointment, you send them their notes, you send them the post-operative instructions, whether it be for a endo, whether it be post-op instructions for an extraction. If they're in London, they'll also get a feedback form, which goes automatically. And if anyone wants to see the feedback they're getting, if anyone's feeling a bit down or wants to see all the good feedback they're getting, ask, we can send it to you, you could see it. Most of the feedback is brilliant. Somebody I showed it to the other day, I showed you all your brilliant feedback. I realized there was one negative one, but so what? You've got lots of good ones. Don't worry about the negative. Okay. If the patient does not have a dentist, you've done whatever you're doing for them. Have a quick look around the mouth, not an examination, but a quick look as you're going. Do they need anything else? You then write in what they may need in one of these columns. Maybe they need an extraction. Maybe you might put upper left quadrant, maybe you'll put upper left six, depending on what it is. You don't have to be prescriptive. You might put upper left six question mark because you don't want to be too prescriptive. The tooth's broken in half, there's no doubt it needs to come out, but you don't want to be prescriptive to your next colleague because you don't want to promise something the next guy might not want to do. You might put down there's a simple filling or a complex filling, whatever it is. Clearly, they're not going to get an MODB palatal filling on their next appointment. They've got half an hour with this patient. Maybe they need some perios. If they've got, scaling and polish, no, but if they've got lots of calculus or clear perio, book them in for it. Something else, write it in what you think it might be. Right. In London, we don't have a dental practice associated with this patient. If you see a patient who you like and wish to treat at your own practice, by all means, go ahead. You then tick this, refer to own practice. That means dentist own practice. Refer to own practice on the NHS, privately, whatever you want to do, if that's what the patient wants. I'm happy for you to take them back to your practice. I'm happy for you to pick and choose. This patient's a quick band 3 and I like them. I'll do it. This patient's a complex case. I won't do it. This patient looks like they want to spend lots of money with me. I'll take them to my practice privately, whatever it is. As long as I don't find out people are spending 25 minutes trying to upsell them to private practice, I don't mind what you do with this patient. You could refer them to the NHS website. That's basically a way of saying go away, because nobody's really taking on NHS patients in great detail at the moment, I don't think. If anyone is routinely taking on NHS patients at their practice, please let us know in the chat. Yeah, so is everyone else on that. That's why I feel I've going through it again. It's not you. No follow-up indicated. You've had a quick look around. You haven't seen anything that obviously needs doing. Fair enough. But you put something, one of these 8 boxes needs to be ticked for every patient. Sometimes 2 boxes, but sometimes just 1, but at least one of them. If you haven't ticked anything else, then it's no follow-up indicated. But even then, they probably need to go and find a dentist somewhere. Although they might have one. I've got a dentist. I saw him 3 months ago. I've got a problem. You sorted it out. No follow-up indicated. Okay. Moving on. I saw someone's just joined. If they have just joined in the last 2 minutes, I guess put them on the register, but probably not a CPD for it. Okay, moving on. The same form in Hertfordshire. Again, it's got to be read. The form's slightly different. We have practices associated with these clinics, so no, don't take them back to your own practice, please. Patient initials, same thing. Have they got their own dentist? If they've got their own dentist that they wish to go back and see, yes, right, nothing else needs to be done. If they haven't, which tooth needs to come out? Simple filling, perio, other, non-HUDC follow-up. Private examination with Leanne's got some very good dentists there that are willing to take new patients on privately. If it's a Berry Lane, it's usually me. Maybe they need an extraction. Look, it's a difficult extraction, but somebody might want to do it. It's an RCT. Which tooth? I've got the microscope. I'm happy to do pretty complex cases. Might want to do it. NHS waiting list. Both practices. Leanne, if you currently got an NHS waiting list, you just close right now. So Rickmansworth, we have an NHS waiting list. We've got 300 patients on it. None of them are ever going to get seen, or very few of them. Occasionally somebody gets an appointment, but they can go on it. Signpost to NHS UK. Again, people can look for a dentist, but they're not going to find one. Or no follow-up indicated. What would I recommend a patient who has been seen on urgent care and doesn't have a dentist? You've got other treatment needs. The best thing that you can do, if you were my family member, is find yourself a high-quality private dentist. I don't know how you define who a high-quality dentist is. You might find somebody who's very expensive, but not very good. But that's the ideal thing. And there's plenty of dentists here on this call that are high-quality dentists that do private dentistry. If I had a problem, I can see who I would go to. I can see very clearly who I went to. And they did a great job for me. The next best thing, if somebody can't afford that, and many of our patients can't, we have to accept that, is find yourself an NHS dentist who will take you on and do comprehensive care. Unfortunately, not a lot of dentists are taking patients on at the moment. The next best thing is episodic care. That's what we're offering. Bring patients back for episodic care is what we are doing. Sometimes it's a private referral in-house, but very often it's just, yep, Suraj and Mange, thank you very much. We're going to go on for a couple more minutes, but yeah, go see the patients. They're the priority. We will see you soon. But that's really where we're at. That's the next best thing, is to bring them back, to get something else done, get them as much out of problems as we can. As an aside, if we are referring on the NHS for secondary care, we are supposed to charge the patient band 2, guidance to follow. That needs to be discussed with the dentist. I'm going to share my screen again. Oh, let's go. Share screen. There's one more slide. Right, the next lecture is on the 10th of June at 7 o'clock. Never mind, put it back up there. Is that showing? 7 o'clock, why do different dentists treat patients differently? And all our lectures will be available on our YouTube channel, or they are already on our YouTube channel. I'm going to end the
Scott, you're
recording.